Okay,
All right.
hold on, it might be echoing. Let me get off from my phone.
All right.
Or
All
let me, how
right.
do I mute this?
Let's see. We got Mariah. We got Naomi. Let's see. Um, Katria, Maisha. Please tell me if I'm saying your names incorrectly. I don't want to say your names
You said it
wrong.
correct.
Thank you.
You're welcome.
Is it Danae?
Danae, yes.
Awesome. Joanna?
Yes.
Oh, yay. Okay. Amani is here. Aiden is here. Jacqueline, Sydney, Jessica, Marcus. Marcus, no, she said no. What's wrong? Marcy. Okay, got it. I'm just going by what's on the roster, but I see it now. Marcy. Okay. Felicia, Joseph, Ashley, gotcha. Jackie, Rupert, Jackie. Where's Jackie? I do not see Jackie. All right, so we're
She's not
missing.
gonna be able to make it today.
Okay, thank you.
You're welcome.
And then, oh my gosh, my glasses. Katiana, is that correct? Awesome. And then Shaquana. Oh, and I missed one. So I don't want to say this wrong. Where are you? I see you. Is it Miantala? Myantala?
It's my aunt Tala.
Myantala. Awesome. Okay. I was like, let me not say that wrong. All right. So great. Awesome. Well, welcome. We're going to try to make this as great as possible. So welcome to week 2 of nursing care of the older adult. All right. So, for this week, and just bringing up the overview, we are going to discuss, what are we going to discuss? We're going to discuss overview of aging. We're going to talk about some theories. We are going to talk about health promotion of our older adults. And then we are going to talk about some elder abuse. So those are the topics for this week's. And so you have lots of resources in your modules for this week. I have posted the PowerPoint for this week as well. So you do have that available to you as well. Um, Anybody having any technological issues at this point, everybody is able to access everything that they need to access
Are we have a test next week, right?
for week 3.
Yeah.
Mm-hmm.
All right.
Yep. So you have, as everybody has looked at the what do you call it? The review schedule. The review schedule is posted. Everybody has looked at that. Has anybody attended any as of yet? Yes, awesome. All right, so keep an eye on the review schedule. I believe there's almost one just about every day, right? And then I think on the weekend there's like 2 each day that are available for you guys to attend. So best, always good to attend the live reviews. This way you can ask questions, but all of the live review sessions will be posted in the announcements, so you will have access to the recordings. Okay. So know that those are going to be available for you as well. So that if by any chance you do not, attend one of the live reviews, there's going to be in the announcements. And it's always good too. You have different instructors doing the live reviews, so you can get a different perspective, right? Maybe they explain something a little bit different, right, than I would, or somebody else. Live review attendance is not required. It is not required. It is strongly recommended. All right. So it can't make you go. But it is recommended that you go because you're gonna, it's a review of all the material. And so you can get, that additional information. The more you hear something, right, sometimes the better off you are. So it's always an extra option. All right. So with that being said, we are going to get started. I'm going to share my screen. As soon as this PowerPoint opens up for me, I will share my screen. And we will go ahead and get started. But does anybody else have any other questions before we do get started? Everybody's good? All right. I also posted the exam one review PowerPoint for you guys as well. So you can look at that too.
And that's for exam 1, right?
Yes, exam one, sorry. Yes.
Yeah.
All right. So everybody see the PowerPoints? All right, everybody can still see me? Yes. All right, perfect. All right. So HESI highlights for weeks 1 and 2, overview of aging. So when we look at that, there's going to be 1.4 billion adults age 60 plus by 2030. That's a lot of people over the age of 60. 2.1 billion by 2050 worldwide. And so, what you're see in the nursing homes and things like that. Those are not the majority of our older adults. Most are capable of engaging in healthy, independent living. To look at some theories of aging, psychosocial, biologic, as well as developmental, your health promotion of older adults, maintaining health through recommended screenings and immunizations, right? There are pneumonia vaccines, there are flu vaccines, the shingles vaccine, getting their recommended screenings, mammograms, colonoscopies, other screenings, preventing accidents and infectious diseases, promoting safety, especially fall prevention, right? Give me some examples. What are some things that increase the elderly person's risk for falls? That's a tough
And
question, right?
what, the environment, as far
Okay,
as like
the
the
environment
environment?
they live in. Okay.
Yeah.
Medication,
Say that again.
medication,
Medication.
medication,
Medication,
They're,
absolutely.
they're not
Illness.
able to see as well.
Not be able to see as well, right?
Clutter in the house.
Clutter in the house, right?
Surgery.
Surgeries,
Illness.
lack of assistance,
Disabilities.
disabilities. Yep. Also too, as we get older, unfortunately, there's a lots of changes that occur within the body. And so one thing, as a result of that, one of the big changes too within the nervous system is we don't have the ability to regulate as well. All right. So orthostatic hypotension is very common in the older person, right? They just can't regulate from going from a lying to a sitting to a standing position, which also increases the risk for falls. So good job. Yeah. Nutrition, hydration, weight control, the older person has nutritional needs, right? Just like we do. Changes in taste, difficulty swallowing, right? Those can all lead to decreased intake in our older adults. And then if, they have any incontinence issue, right? If or mobility issues, if it's hard for me to get up and go to the bathroom, then what am I not going to do? I'm not going to drink, right? Because then that's just going to make me have to go to the bathroom even more, right? So it's a vicious cycle. Um, social interaction to avoid isolation, right? How do we get that older person who may not have any transportation, may not be able to drive, or has a disability and isn't able to drive? How do we get that social interaction so that they aren't isolated? Of course, discouraging excess use of prescribed medication and over-the-counter medications, right? That polypharmacy that we often see in our elderly population, right? They're on medications for blood pressure and high lipid levels and diabetes and a variety of other, right, chronic diseases. And lots, maybe on lots of medications, right? So doing those medication reconciliations, and really looking at them and trying to decrease the amount of prescriptions that they're taking. And then elder abuse. So we'll talk about the types of abuse and neglect, the risk factors for abuse. And, of course, as healthcare professionals, we have that legal responsibility to report abuse, right? And so in your HESI book, it's chapter 8. So you can look in there as well. So we'll start with some health promotion, health maintenance, home health considerations, your oh my gosh, your learning objectives for week 2. So health promotion, and you guys have all heard this term before, but health promotion is the process of enabling people to increase their control over and improve their health. Right. And so health promotion, think about some of the things that we can do to make our health better. A lot of times this is going to require a change in behavior, right? We have to adopt those healthier lifestyles, right? So eating better, exercising more, what else? Quit smoking, not drinking as much, right? The long-term success is going to depend on that person's ability to adapt to a change. How willing are they to make the change in their lives, right? To lead healthier lives. How easy do you think it is for most older adults to make a change? Do you think it's easy? Think about
Very
yourself.
hard
Not easy at all,
because they
because they think
stubborn in their
because they're older,
ways.
yeah, they stuck in their ways.
Right? They are stuck in their ways, right? Just think about us, right? How hard is it sometimes for us to make a change, right? If I told you that you had to drink a gallon of water every day, how many of you can commit to that for a long term?
I can.
Okay. But, think about that, right? How difficult would that be? Or, to tell you that you needed to go, get up every morning at 5 a.m. and walk for a mile before you go to work, before you go to class, right? Before
It'll
you do
take time to
anything.
adjust.
Say that again, Chiquana.
It'll take time to adjust.
Right. How long does it take to solidify a habit? Anybody know?
A month?
Not long at all.
21 days. We're
21
very
days.
close. That was good. It takes 21 days to make something a habit, right? So not a horrible amount of time, right? But still enough time where people can start to do something and stop, right? So 21 days to get a habit started or to make a
Mm,
habit routine. And
right.
so some of the exemplars of health promotion would be nutritional counseling, physical activity, mobility, screenings and vaccines, your dental and oral care, and then of course our injury prevention, our fall prevention. Those are all going to be some of the key parts of this. Recorded. All right. So health practices for our older adults. For one, a well-balanced plant-based diets, right? Avoiding the processed foods, the canned foods. We want them to increase their fruits and vegetables, right? So nice, well-balanced diet, getting exercise, regular exercise, 30 minutes at least 3 to 5 times a week. All right. So what does that look like for an older adult? It could be, walking around the neighborhood. It could be, going to a gym, or, something along those lines, or even exercising in their home. But we do want them to get regular exercise. The exercises should be weight bearing as well, right? That's going to have a better effect for their bodies. They should quit smoking and drink in moderation. Um, and then routine immunizations and health screenings. So most providers will do lab work and things like every 6 months to keep an eye, especially on those chronic diseases. Stay involved in activities with others, and keeping a healthy, positive attitude. So what do you think? What are some ways that if we have a elderly person, so just something to think about, say you have an elderly person that doesn't drive, that has limited resources, think about what are some ways that we can get them to be more, to be socialized, right? So that they don't become isolated. Um,
Miss
so,
Martinez,
these are things that we do have to think about. Um,
did Sydney come back on? Because she said her computer froze.
no, she's still, I think, still frozen.
She's trying to get back on. I'm just letting you know.
Oh, okay. Thank you. Yes, I will. As soon as she in. Yeah, she looks like she's frozen. Shaquana, is your camera working?
I'm using my phone. My front camera messed up. I go get my laptop and try to charge it up.
Okay.
I left my charger at school.
Oh, okay. So your diet, well-balanced diet based on the dietary guidelines for Americans. Who has been to the myplate.org website? Has anybody looked at the myplate.org website? Really great resources on that for every age. So it can really help them to plan meals, right? They need to have a protein at every meal, reduce sodium, reduce sugar, refines carbohydrates. We want high fiber foods that are high in vitamins and minerals and lean proteins. So why is it important to read nutrition labels? Anybody look at nutrition labels? Has anybody looked at them? Some of them are very surprising, right? When you look at some of them.
Yeah. I look
What
out for sodium a lot.
sodium? There's sodium in everything, right? And
Yeah.
some of it is ridiculously high,
Yeah.
right? When we look at some of the foods that are out there, obviously more fresh foods are going to have lower levels of sodium, but why do they use so much sodium in some of those
To
processed
preserve
meats?
it.
Preserve it.
Right? It's a really good preservative. So that's a lot of reasons why the sodium levels are so high. But what else sodium is another one. What's another one that we need to look at?
Sugar.
Sugar content, right? Sugar and carbohydrate content, right? Especially for diabetics, right? Looking for the hidden sugar, in foods. Awesome. So, most sodium and sugar in processed foods are hidden. All right. So foods that don't taste salty, that doesn't necessarily mean or foods that taste salty doesn't necessarily mean that they have the most sodium in them as well. Right. So, some foods, if you think just are just naturally taste a little bit salty, but again, being aware of sodium is more effective than, restricting your table salt, because your table salt, you have the ability to, right, control
Control
the
it.
amount of sodium and
You
salt that you're
control it.
putting in
Yeah.
your foods, right? If it's already in the foods, right, you can't take it out, right? It's there. There's no way to get rid of it. Another big thing that people don't always look at is the serving size, right? You get a can of soup or um even a package of sandwich meat, right? Looking at the serving size. The serving size, the calories is per serving. Okay. So if this is, this serving size for whatever this is a cup and a half. All right. And so for that cup and a half, there's 240 calories. And this is all per serving. So there's 4 servings in here. So 4 times
Mm-mm.
that 1.5. So what is that? 2 would be 3. So that's 6 cups. Then you multiply each of this by 6, right? And that is what's going to give you the total for the container. So paying attention to serving size is important, just as important as the ingredients, right? Because the more you eat, right, these are all going to go up, right? Does that make sense?
Mm-hmm.
Oops. Exercise. We all know the benefits of exercise, right? It keeps us flexible. It helps us to maintain muscle. It can help with our weight control, maintaining our glucose levels. Also gives you a sense of well-being, right? Exercise makes you feel good. Anybody like to exercise? It's always a loaded question.
It's
Okay.
relaxing.
I'm sorry.
It's relaxing. It helps you sleep, believe it
It
or not.
does. It can help you sleep. Absolutely. Right. But it does. It gives you a sense of well-being. It does make you feel better. It doesn't have to be aerobic. It doesn't mean that you have to go out there and run or what are some of those other kickboxing or some of those that aerobic type exercises, right? You can do other exercises. Yoga is a good exercise to do as well. Lots of stretching, right? Really can help maintain that flexibility, build those, maintain those muscles. But again, it should include 30 minutes of continuous activity 3 to 5 times a week. Um, Older person can repair damage once they quit smoking. So if they quit smoking, they can repair some of the damage that has occurred in their lungs by quitting smoking. There's a variety of different aids out there to help someone quit smoking. There's gums, there's lozenges, there's what else is there? There's patches, right? I saw another one. I was looking at something. I don't know. I didn't do the research into it. But it's another little device to help as well to quit smoking. So there's a variety of things out there to assist. Um, but they can repair some of the damage that has been done. Alcoholism is another common problem, right? So reducing alcohol intake is also something that we would potentially want to look at. How, well, no, I'm going to save that question for later. All right. And then, like I said, our annual screenings. All right. So getting your annual physical exams. Older people still need to get their cervical screenings, right? So pap smears, their breast cancer screening, so their mammograms. What is bone density screening? What does that help me to see? What is bone density screening?
Is that to check the strength of their bones?
Okay, the strength of their bones. And what
Is
are
that
we
the same
looking
thing as a
for?
DEXA screening? Is that the same thing?
Say that again.
Is that the same thing as the DEXA screening?
The DEXA scan? Yes.
DEXA scan. Okay.
Yep. Yep. Why is that important? Why?
Because as they age, their bones get weaker. So the DEXA scan checks like the what do you call it? Not the
And they
protein in the
start to
bone, but it
contract.
checks how fast their bones are deteriorating and stuff.
How fast they're deteriorating. Um, and so what bone density screening we're looking for is osteoporosis, okay, or osteopenia. Um, and so if we can detect the osteoporosis and the osteopenia, right, that may allow us to start some early treatment, to try to prevent fractures, right? So it is, there's really no symptoms of osteoporosis. So if we do the bone density screening, right, that may help us to identify this, if there's any issues as well. Of course, colon cancer screening, vision screening, getting your eyes checked, getting your even sometimes getting your hearing checked, um, dental exam, blood tests, all of that. So here we go. What is the preferred screening exam for colorectal cancer?
Colonoscopy?
Colonoscopy. Very good. What is the preferred screening exam for breast cancer?
Mammogram.
Mammogram.
Very good. So we talked about the DEX exam. What age should we start our our screening for bone density? Anybody have an idea?
50.
Okay.
65?
I like 65 better than 50.
Your word, I just turned 50. You trying to say I need a bone scan
I
now?
know that's what I'm saying too.
You
I'm over
halfway there.
50.
I'm
I'm
just
not
saying.
there yet.
Halfway there.
I would have went to the doctor today if that's the case.
Um, what are some reasons why the older adult may need to get their vision screened?
Cataracts, glaucoma,
Very good. Cataracts,
Diabetes.
glaucoma. I'm sorry,
diabetes. Yeah.
Diabetes.
diabetes. Yep. Awesome. Good job. As well as what else is out there? Macular degeneration is another one that's common in the older adults. Um, and then how often should an older adult with no risk factors for heart disease have their cholesterol screening done? If they don't have any risk factors.
Every 6 months to
Every
a year.
year.
Yeah.
6 months to a year. Yeah. I agree with that.
Okay. All right. So let's go. So here is your
4 to
answers.
6 years. Yeah.
Oh,
4 to 6
wow.
years, but you got to remember that's no risk factors. Like no risk factors, no
Yeah.
what's the word I'm
No
looking for?
hypertension, no
Nothing, right? You're
nothing.
in
You gotta be
perfect
clean.
health, no family history, no nothing every 4 to 6 years. But
So
good job.
when they do their annual wells every year, they wouldn't check that, like when they're doing blood work and that kind of stuff.
Most places do. But the guidelines are 4 to 6 years.
Okay.
But it's also, again, it's your risk, right? What are your risk factors, your individual risk factors for developing coronary artery disease? A lot of people have, stuff in their family history and things like that, that they get them done sometimes every 6 months, sometimes every year. It really just depends.
Understood.
Um, but yeah, so good job. Colonoscopy every 10 years for average risk. Okay, somebody that's at a higher risk, they may have to get this done a little bit more often. Um, Mammogram every other year. Okay, but they still need the clinical breast exams, right? So the doctor doing the breast exam. The DEXA scan, 65 age, unless indicated earlier to detect signs of osteoporosis. And then you got the cataracts, the glaucoma. So good job. You guys did awesome. All right. So vaccination table. So the CDC, they have, you can go to the CDC website, and you can look at the vaccine schedule. All right. And so it's going to look a little bit different than this, but this is very similar to it. Um, and so reading the vaccination table, so the vaccine is listed here, the age is there, all right, and it's going to tell you, and I'm going to pull up the actual one and show you in just a second so you can see it. Um, but influenza, right? Everybody should get their influenza at least annually. Your Tdap is either Tdap or tetanus is every 10 years, right? The pneumonia vaccine, one dose at age 65 or older. And then we have the pneumococcal polysaccharide, which is one dose 1 year after the first vaccine. And so we do have a single dose vaccine for pneumonia as well. So it's kind of it's different. But I'm gonna stop sharing this screen and I'm gonna switch over and I'm gonna show you if you go to the CDC website, you can look and the vaccine schedules are there. So even if you had kids, or you're just curious about the vaccine schedule, again, this is the CDC vaccine schedule. It does tell you, kind of some of the recommendations as well. And so this is kind of how it reads. So yellow is recommended, right? Green is catch up. Purple is for certain high risk populations. when vaccine can begin. So there's a variety of different colors that you're going to see, right? But here are your childhood immunizations, COVID vaccine. So you can see here, COVID vaccine starts at age 6 months, right? So we can give them at 6 months. And then you can go down, it goes all the way up to 18. And if I were to go back, let's see, adult immunization schedule. Here we go. All right. So here it is, right? It's kind of like what you saw on the slide, right? So 19 up to greater than 65. It gives you all of the recommended vaccines. Some of these, okay, they've already had, right? You had your polio as a kid, your Hib, your your meningococcal, your hepatitis B, your hepatitis A. All right. So it really, some of these are just on here in case you've never had them. But again, the flu, the tetanus, the pneumonia, those are going to be the ones that we really want to pay attention to. And then, of course, we do have the herpes, the shingles vaccine is another one. It is a 2-dose series. So just looking at it and being able to understand the vaccine table is important. And it kind of will give you, like I said, it just tells you what vaccines. Now, you can also go to the CDC website, just as FYI. Let's say that you want to travel out of the country. All right. And you need to know if there's any specific vaccines that you need to go or need to have in order, to go visit whatever country you want to go to. You can go to the CDC and they'll have that information for you as well. All right. Let me switch back. All right. So Mrs. Scott is 71 today. Or no, I'm just kidding. She's 71. Today she's here for her annual exam. All right. And the LPN is reviewing Miss Scott's records and sees that she has had the following immunizations. So she had her shingles back in 2020, her pneumonias in 2024 and 2025. She had her Tdap or her tetanus, I'm sorry, in 2015. And she had an influenza vaccine in November of 2025. So which vaccine or vaccines will the LPN administer to bring her vaccines back up today?
A TB booster.
Yeah.
The Tdap.
The Tdap. Awesome. Yep. So Tdap and
And flu.
potentially the influenza vaccine.
Mm.
All right. Dental care. Everybody goes to the dentist like they're supposed to.
Every 6 months.
Yes, ma'am.
Good job. So, yes, okay. So they should still go to the dentist just because they're older. So dental exams should be annually. A lot of people do go every 6 months, right? Like, if they wear dentures, they still need regular dental exams because those poorly fitting dentures need to be adjusted to prevent gum pain, poor food intake. Imagine if you wear dentures, okay, and they don't fit right. They're too small or they're too large. Okay, imagine what that feels like when you're trying to eat and chew or even talk. Imagine your dentures don't are too big and you have them in your mouth and you're trying to talk and they're slipping and they're constantly moving or even potentially falling out. Um, so we do need to make sure that they fit appropriately. Older adults, they may have dentures. What if they have something happens, they lose a lot of weight. Those dentures are not going to fit appropriately either. So we need to make sure that they get adjusted appropriately. They need to be cared for. Dentures are expensive. I'm not sure how expensive, fortunately, knock on wood. But dentures are expensive. I just know dental work is expensive, period. So I can imagine how much dentures cost. And we need to make sure that we're caring for them and treating them appropriately. So they can be brushed just like you brush your teeth. You can brush your dentures. Okay. There's like the, what is it, like Effordent and some other
Mm-hmm.
things that you can soak them in overnight, right? That can also help to keep them clean. Um, Dry mouth is common with people that wear dentures. That can also lead, or I'm not when people wear, it's common in older adults, my apologies, which also can cause poor nutrition and digestion. So imagine your mouth is dry. What happens when your mouth is dry? How does it feel?
Uncomfortable.
Uncomfortable. How does it taste? It
Terrible.
sounds weird. It tastes
Stalky.
horrible, right? It's like waking up in the morning and you've been, some people are mouth breathers, right?
You
You're
got
breathing
dry
through your
mouth.
Yes. And it's just, right? That can also cause some poor nutrition and digestion issues, right? So there's things that we can do for people that have dry mouth. There's things like artificial saliva products that can be made to help lubricate the mouth, right? And then, of course, if your mouth feels better, right, then you're gonna want to eat and you're gonna want to drink. So when we look at this, and not some of us are a little bit older, but most older adults health practices are formed early in life, right? So think about it. As a young adult, right, how often do you go to the doctor? How often do you get your labs? How often do you go to the dentist or go to the eye doctor to get your eyes checked? Right? We say, what did we say? 21 days to make a habit a routine, right? And so these are all things, if these are things that you do now, right, then you will continue to do them as you get older. And so it is important that, people understand that, the recommended health practices, right, that's needed to make good choices. So they should continue good practices as they get older. And we know patients have the right to refuse or choose or decline care, or, they have that right. So some people consciously make the decision, I'm not going to the doctor, right? I don't want to know if there's something wrong with me. You do have people are like, oh, or they'll just ignore symptoms, right? Until they get to the point where they can't ignore them anymore. Adherence means following through with the treatment plan, right? Sticking to the plan. Why would a patient be non-adherent with a treatment plan? What are some reasons why somebody would not follow their treatment plan?
Not
Trust.
affordable.
Or they don't.
Financial issue.
Financial issues is a big one, right? How much does it cost to go to the doctors or pay for the medications or the copays and the deductibles, right? It costs money. Um,
Cultural.
Say that again.
Cultural.
Cultural, absolutely. Culture
Trust.
plays a big part.
Lack of access to resources.
Lack of access to resources. If they can't get to the doctor or they're in a rural area and there isn't a doctor for 50, 70, 100 miles, now, of course, I'm not going to go to the doctor, right? That's a big one. What are some other ones?
Trust.
Say that again.
Trust.
Oh, I like that. Trust. Absolutely.
Probably a language barrier.
Okay, language barriers. They didn't understand, right, what the treatment plan was. Absolutely. What about medications? What makes people non-adherent with their medications?
Lack of education.
Lack of education. That's a good one.
They might be into holistic care.
Okay, they might be in holistic care and they don't want to take the prescription medications. Okay.
Back
Cost
again to
is
finances.
right. Absolutely. We can always go back to finances with that, right? What about side effects?
Yeah, they could be afraid of
Too,
the side effects.
Yeah. Or
too
they,
many.
yeah, or there's too many side effects,
There's
right?
too many.
I'll
Yeah.
take the medication and they have the side effects. And well, I'm not taking that again because it did this, this, and this, right?
The way
So
it made
I
him
don't
feel
remember.
previously, yeah.
yep. Very good. Yep. So yeah, there's a variety of reasons why that people are not, adherent to their treatment plans. And that's where education plays a huge part in it, right? Education, that open communication, right? Trying to get as much information about the reasons why. And it can be cost, it can be cultural, it could be distrust, right? There's so many different reasons why people would choose to not follow their treatment plan. And for us as nurses, right, that's our job. We need to understand why or try to find out why. We may never change their mind, but right, but we can provide the education, right, and give them the information because we know knowledge is power, right? And the more knowledge somebody has, the more power that they have, the more freedom they have to make choices. Good job. All right. Impact of changes related to accessibility. Oh, so maintaining our health is affected by sensory changes, not able to get around, decreased stamina, lack of transportation, limited finances, right? These are all things that we've already mentioned, right? And I can't hear, I can't see, right? That's going to definitely impact my accessibility, right? Just like somebody said, right? You didn't understand. Maybe it was it could be a language barrier. But if I can't hear you and I'm just nodding my head and like, yeah, I get what you're saying, but haven't heard a word you said, right? Or if I can't see well enough to read the labels or to even read the directions on my medication bottle? Or what if I can't see well enough to um, pull up my insulin into my syringe or dial the insulin on my insulin pen, right? So sensory changes are a huge part of that. Decreased physical mobility. Stuff happens. We get older, all right? Some people led some rough lives, right? Hips and knees, ankles, shoulders, elbows, right? Things don't work as well. And so, this is also, something that we have to look about, how do I get around? Just like I said earlier, right? If it's hard for me to get up out of the chair to go use the restroom, I'm not going to drink as much because that means I don't have to get up to use the bathroom as much, right? So it ends up being a very vicious cycle. Decreased stamina, you can run that 30-mile marathon, back in even your 40s and your 50s, but maybe by 60, 70, 80 years old, you're like, oh, I can't do that anymore. And that's of course extreme. Okay. But decreased stamina is something that we have to take into consideration. They may have been able to walk a couple miles, but now as things have started to slow down, right, then they may not have the stamina. Lack of transportation is a big one, as well as limited finances. A lot of our older adults live on fixed incomes, right? Don't have that extra money to just kind of throw around, right? And they have to make decisions about how to, what they're willing to buy and willing to pay for versus what they're not willing to pay for. Home health care. So aging in place, this is a big part. When we look at that older adult, I promise you it's not every older adult's dream to go live in a long-term care facility, okay? Right? We absolutely have a need for long-term care for the debilitated adults who can't take care of themselves at home, whose family can't take care of them, or they don't have family to care for them, right? So we have long-term care for those people. But it's most of us, it's not our goal to go live in a long-term care facility when we get older. And if I do, I promise I'm gonna be one of those really crotchety old ladies too, when I go in there. But home health care, the older adult can get assistance from family and friends, right? They may be able to live in their home, and maybe they have family or friends that come in and check on them. There's also, of course, if they qualify for home health through a home health agency, right, then they'll have access to the RN, the LPN, the CNAs, therapist. Sometimes there's even volunteers that work with home health to help with certain things as well. What's hospice care?
Is that the same thing in policy
End
care?
of
Like,
life
try to
care.
get them comfortable before death?
So hospice care is it's end of life care. Okay. So as somebody is, usually with hospice care,
Transitioning.
they have to have a terminal illness. It's usually 6 month prognosis. And it's the premise around hospice is death with dignity. Okay. So in maintaining as much quality of life as well as ensuring pain control through their end of life. Hospice care could be done at home. It can be done in a long-term care setting. It can be done in a hospital. There are even some that have hospice homes where all they do is to care for hospice patients. Um, so those are just some different, but home health care, they do have to have a need for home health care. Being old isn't just, doesn't just give you the need for home health. They have to have some other condition, a skilled need, in order to qualify for home health care. Um, but there's a variety of different things out there. All right. So any questions?
So hospice is only 6 months or less.
For an adult, it's generally they have to have now it doesn't mean that they have to die within 6 months, and that's probably didn't come
Okay.
out the way I didn't mean it to come out the way it was
Yeah,
intended,
because
but
I
it
got
did.
patients who've been on hospice for a couple of years now.
Yes. Their diagnosis has to be terminal, and
Okay.
and it's usually 6 months or less.
Okay.
Okay. Now, yes, I know patients that have been on hospice for years as well. And so, yes, generally speaking, it's 6 months or less. But yes, just because now, you might have them that fight and fight and fight, right? They're fighters. They're going to live longer as long as that they have to have the terminal diagnosis, though.
Okay.
Oh,
Thank
yeah.
you.
Yep, absolutely. Yeah, so I have a hospice patient now, which I just thought was the most interesting thing. So I'm from Virginia, so I think I told you guys that like I've been in Virginia for 30 years. We just moved to Texas and things are different. I worked with hospice patients when I lived in Virginia, in long-term care as well as even, when I worked at the clinic. But um, I have hospice patients here that are still full codes. They are still full codes. And so
Now, why is that?
Full
I,
code in hospice?
okay,
Yeah, I
thank
don't.
you.
Yeah, I got a
Thank
couple
you.
too. Why is that?
Isn't this supposed to be
That makes
comfort
no
care?
sense.
That is my biggest argument. That is one thing that I just could not understand when I started working here in Texas.
Hmm.
Because yes, we have hospice patients that are still full codes. So,
Crazy.
yeah, it's just interesting that, yeah, it was something that was just totally blew my mind.
So is
Um,
that more of a money thing?
I don't know. I still can't figure it out. Nobody has been able to answer that question for me. The other thing that I saw was so because I didn't get in trouble, but I was confused and I didn't notify the right provider, which was, like I said, I didn't get in trouble. I just didn't notify the right provider. So we have a patient, she has Alzheimer's. Okay. And she is hospice for her Alzheimer's. Okay. So I'm used to it when a patient goes into hospice care, hospice handles all of their services. Doesn't matter what their diagnosis is, right? They handle all of the services.
Yes.
So the lady was complaining of hip pain. So I called the hospice provider, right? Because in my head, hospice provides all the services. And so down here, Hospice only provides services for the diagnosis of why they are in hospice. So even though I called the provider, I got the hip x-ray, like I did, they got the care that they needed. There wasn't a fracture, but they got the care they needed. I was not supposed to have done that. I was actually supposed to go through her regular provider because it wasn't under the Alzheimer's diagnosis. So there was a lot to learn when I came down here about how they do things. It is very different. Um, so for those that go on a temporary basis, they should, so it is interesting. It when we look at, putting patients on hospice for the extra supplies and things like that, I have seen that done because they do get extra benefits. And that means that the facility doesn't have to pay for those additional supplies for that hospice
Mhm.
patient because it's covered under hospice care, even down to their briefs, right? Hospice will provide their briefs, their medications. They'll even bring in their own bed, which I never could understand that too, because, they're in a perfectly fine hospital bed, but yet hospice will bring in their own hospital bed, their own mattresses, all of that. So it could be so that they get extra benefits and extra supplies. So
And
it's
also because of
interesting.
the comfort of it. I want to work hospice when I'm finished with school, actually, but
Oh,
my
good.
uncle
Okay.
passed away about a week and a half ago, and he was in hospice care. But like the transition from him being nursing home, and he was in an amazing nursing home, but the transition from nursing home to hospice, he was only in hospice for less than 48 hours. We had him on comfort care. Um,
Oh,
he had dementia, so like he stopped eating and all of that stuff, and the doctor was just like, it doesn't make no sense to put a peg tube in him and all of that. Like, it's literally he's not here. It's just
hmm.
his body is here at this point. But yeah, the staff he was an Allied. I don't know if anybody knows Allied, but he was an Allied, and they were amazing. Like the beds were better than the hospital. And one thing about the facility that I liked, it's only 4 rooms, so
Oh,
it's
wow.
like more of a small personal facility. Whereas you don't have too many people in there, which is comfortable also because if you're at the end of life, you have your family there. You don't want to
Hmm.
be there with 1,000 other families, and then you're grieving and all of that. So it was an
Absolutely.
amazing facility. I liked it.
That's awesome. Yeah, some of them are awesome. I've come across only a couple. I would say in my time working with hospice, I've only come across maybe two nurses that should probably find another another field of nursing to work in because hospice was definitely not their calling. I personally, I've never worked hospice as a hospice nurse. I have provided hospice care working in long-term care. Unfortunately, even if they're not in hospice, you still provide end-of-life care for patients as they decline. Although lots of kudos to hospice nurses because, like I said, the majority of the hospice nurses from even working in pediatric hospice to adult hospice, they have been absolutely amazing. And when my mom was in hospice, her nurse was absolutely amazing. So nothing but respect for hospice nurses.
Miss Martinez,
Um,
if you don't mind
yeah,
me asking, what's the
yes.
difference between a hospice nurse and someone that just provides hospice care? And in the sense of like you getting care in your home privately.
So the hospice, I mean, it's still, so if for like home health versus hospice, is that what you mean?
Yes.
Or so home
Like
health,
the person is on hospice, but they're just at home
it's still
because
hospice. Hospice
like
nurses will come into the home.
like sometimes the family hires like private like a private care person to
Hmm.
provide the care, but then they also have the nurses that do the same thing. So like what would be the difference between that if you kind of get what I'm saying?
So hospice doesn't provide 24-hour care right
Okay.
now. Like if something happens, if they start to decline or something occurs, right, then the hospice nurse will come. But it's still not 24-hour care like a nursing home. And
I
so
see
a
what
lot
you're
of families will hire caregivers for that 24-hour care. And then when the hospice nurse needs to be there, then of course the hospice nurse will come in.
saying. All right. Thank you.
Yeah, you're welcome. All right, I do need to give you guys a break. So the next part of this, real quick though, we're gonna do fluid balance and nutritional needs. So think about this while you're on break. What influences our caloric needs, and be back at 4:15.
Fran.
Hey girl.
Hey girl, can you check for my charger and med surge?
Yeah, I'll be right
All
back.
right. Hey girl, Danae. What's up, Joseph?
Okay, is this it?
You say HP? Yep, that's it. They got a boot thingy.
Oh yeah, I
Oh, you fried.
do.
I was trying to FaceTime you. It ain't working. You on your tablet or you on your tablet, ain't you?
Yeah,
Oh, okay.
that's where my phone is. Okay,
All right. Thank you.
all right.
I just want to get paid.
All right. So, give you a quick question to think about while you were on break. So, what are some things that influence our caloric needs? Oh,
Not having enough time.
okay, time. What else?
Our age,
Our age, absolutely.
physical activity.
Our activity level.
Children.
Can't we go back to finances on this one?
We can go back to finances on that one.
Muscle
Okay.
mass.
Muscle
Children.
mass.
Hold on, wait, friend.
Okay.
Stress
All
and
right. So
medication.
medications, absolutely. So, yep. So age, gender, activity level, your health, your emotions, climate also influences our caloric needs, right? So think about it. Um, People live in colder climates, right? May need some extra foods, extra calories, right? To meet their metabolic needs. Um, but your health, emotions, right? Think about it. How does emotion affect your caloric intake or your caloric need?
Makes you eat more or less.
Right? Some people eat more, right? When they're upset or they're going through something, right? And then others eat less, but your emotions definitely play a part. The minimum daily intake to meet our nutritional needs is 1,200 calories. How many people pay attention to the number of calories they eat in a day? I don't either. I'm not gonna lie. I don't pay attention to it, right? But the minimum amount is 1,200. So things that, diseases that restrict mobility, right? Your musculoskeletal, or your activity, whether it's physical or metabolic, are going to affect your body your BMI. Um, Imbalanced nutrition, more or less than body requirements, right? Too much, right, is obesity. Too little, we become frail, we become very thin, right, and unable to care for ourselves. But too much in nutritional intake. What are some problems associated with being overweight?
Medical problems or just problems in general?
Just problems in general.
It makes
Mobility issues.
Yep.
Mobility
Respiratory
issues.
issues.
Say that again, Joseph.
Respiratory issues.
Respiratory issues,
Knee
sleeping
issues.
issues. Say that's a knee.
Knee issues.
Knee issues, right? Definitely can
Neck
affect our
problems.
joint, neck problems. Absolutely, right? It decreases our stamina, our ability to get around, right? What are some what are some potential health issues medically related to obesity?
GERD.
Diabetes.
Congestive heart failure.
GERD, congestive heart failure,
Diabetes.
diabetes,
Diabetes,
Hypertension.
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 high
I,
lipid
I, I,
levels.
I would say a lot of illnesses.
A lot of illnesses. Obesity increases our risk for certain cancers as well,
Mm-hmm.
right? So here we go. High blood pressure, stroke or heart attack, mobility, skin integrity issues, right? Didn't think about skin integrity issues, but that can be a huge issue in somebody that's obese. Um, and of course, diabetes, depending on the type of calories,
I
right?
can't I can't hear you. Somebody else's TV on or something.
Yeah, I don't know who. All right, there we go. So yeah, absolutely. What are some problems with being underweight? How does that affect your health?
Lack of nutrition.
Lack of
So
nutrition.
lack of nutrition means lack of energy.
Lack of nutrition means lack of energy. Absolutely. So improper vitamins and minerals for body processes, right? So
And
making
that
white
I
blood
think
cells to fight infection, right? Our red blood cells' ability to carry oxygen to the tissue, our iron levels, right? Nerve conduction, muscle contraction, right? Our bone strength, all of those, associated with being underweight. So, and, that's why we always say ideal body weight, right? Want you somewhere in the middle. We don't want you really, really thin and being underweight, but we don't want you being excessively overweight either. Again, 1,200 calories is the minimum requirement. 2,000 to 3,000 mLs of fluid, unless, of course, they're on fluid restriction. Why are older adults at greater risk of dehydration than younger adults?
Sometimes they forget to drink or they're not able to on their own.
Okay. So, yep. They're
They
not
don't
able
want
to
to
drink.
drink.
They don't want to drink. Okay.
They have to go to the bathroom and they can't get back and forth.
Yep, absolutely.
Yeah.
Yep. Um, they also have reduced thirst sensation. Okay, so your thirst mechanism decreases with age, right? So they don't feel as thirsty too. That's a potential issue, right? So if I don't feel thirsty, right, I'm not going to want to drink or I'm not going to drink. Older adults also, here we go. Older adults also have um decreased body water content, right? Most, babies have a very high water content. Older adults have a lower water content. Kidneys become less efficient as we get older at conserving water. So we have more fluid loss, as a result of that. And then, of course, we talked about mobility, right? So lots of different reasons. So here's the percentages, right? So obviously the fetus is 100%, babies at birth are 80% water, and then 70% normal adult, and then 50% for that older adult, right? So that is our total body water composition. So you can see how it changes, right? Start off really, really high, and then we decline. And so here are some of the signs and symptoms that people experience with fluid volume deficit versus fluid volume excess. All right. So I don't know if anybody has ever been dehydrated before for whatever reason. Okay. Um, but with a mild fluid loss, you can experience orthostatic hypotension, tachycardia, restlessness, anxiety, weight loss as well. Anybody know how much a liter of fluid weighs? A liter of fluid is 2.2 pounds. So that is one
So
of the
1
reasons.
pound.
2.2 pounds. Yep.
I mean, not 1 pound, but
A kilogram.
a kilogram.
Yep.
Yeah.
There you go. Good job. Yep. So that's one of the reasons why we put patients on daily weights that have diseases like heart failure, right? Because weight is very indicative of fluid volume status, right? Um, as we get to a more moderate fluid loss, we could have confusion, dizziness, irritability, extreme thirst, nausea, decreased urine output. And then as we get into that severe fluid loss, we could have decreased cardiac output, right? Because there's not enough fluid in my body for my heart to pump that through the body. They can become unconscious, have low blood pressure, weak or absent peripheral pulses, right? Because if I don't have enough fluid, then the body is going to shunt the fluid to the important organs to try to maintain normal organ function. With fluid volume excess, or I've got too much fluid, tachypnea, which is really fast respirations, shortness of breath. They may have crackles in their lungs, a rapid pulse, hypertension. Unless they're in heart failure, then we won't see the hypertension. They could have distended neck veins, hand veins become distended. They'll have that weight gain from the extra fluid, edema, especially in those lower extremities. And they can also have pulmonary edema. So that extra fluid, if the heart's not able to pump it through, all right, we have extra fluid, it's going to back up into the lungs and cause congestion within my lungs. So that is where I would have the shortness of breath, I would have the crackles in my lungs, I would have orthopnea. Orthopnea means you have difficulty breathing when you're laying down. All right. So we have to sit up to breathe. All right. Um, so those are some of the signs and symptoms that you would see. All right. So here we go. Which condition in older adults can cause fluid volume deficit? So hint, 3 out of 4 of these options can cause fluid volume overload. So which ones can cause a fluid volume deficit?
Deficits.
Yep.
History of liver disease.
Okay.
Insufficient.
Compulsive water drinking?
Deficit.
Oh.
Deficit.
Oh.
Deficit,
Mine is
insufficient protein intake.
All right, so we got a couple different answers. So what is it?
A.
It is, yep,
Altered
altered
cognition.
cognition. All right, so think about your dementia patients, your Alzheimer's patients, right? They lose track of how much fluid they consume. Your liver disease, your compulsive water drinking, or insufficient protein intake actually can cause fluid volume overload. All right.
Good to know.
Good job. All right. What are some of the barriers to nutrition for older adults? And we've probably talked about all of these, right?
Finances.
Finances. Definitely,
That's
definitely
a
it's gonna be
number
a
one.
You've got that answer
That's the
down. That
number
is
one
yours.
word, finances.
You own that. What are some physiological barriers to nutrition? We've talked
Carrying
about
money.
them.
They can't really.
They can't get around as norm like they used to.
They can
Like
get around. Okay,
weakness in
absolutely.
the legs.
Okay.
Vision.
The help.
They don't have the help.
Yeah.
Okay. What about
Teeth.
No
No
teeth.
teeth.
Oh, yeah. dental.
right?
No
My
teeth.
dentures don't fit. I don't have any teeth, right? Can lead to it.
Their
All right.
vision. They're not able to read like what's actually
Yep, your
the
sensory
labels.
changes. Good job. You guys are awesome. All right, what about psychosocial? I know this is different. This is the opposite. So this, yes, finances, absolutely. What else?
Mental
Ah!
health. You said mental health.
Mental health. Yep.
Alzheimer,
Mm-hmm.
dementia.
Not having the support, like the support system.
Yep, not having a support system. Okay. Awesome. Not having transportation, right?
Oh
Here,
yeah.
here we go. So physiological, of course, that tooth, the poor dentition, the sensory changes like you guys mentioned. Limited dexterity and mobility. Can't open jars or use utensils as easily. Didn't think about that one, right? We take it for granted. We use a knife and a fork and a spoon, right? Don't have any issues with that. But, there's people that, think of people that have like rheumatoid arthritis or even just arthritis, right? How hard is it? What was I trying? I was trying to, and I'm not older, I'm not 65 yet, I promise. For New Year's Eve, I was trying to make, anyway, I was trying to make a salsa dip. It's salsa and cream cheese. You blend it together. It's super yummy. I couldn't get the jar of salsa open to save my life.
They be crazy
Okay. And
doing
I'm
that
not,
stuff now.
I literally, I had to do the old trick where you take something and you bang on the lid to pop the thing. That was the only way I could get the jar open. Okay. And I'm not 65. So imagine, if I couldn't get it open, I was kind of embarrassed with myself, the fact that I couldn't get it open. But it does happen. Not having the energy, not having the stamina, pain, right? If I don't have the energy, I don't have the dexterity, the mobility, I'm in pain, I'm not going to go cook, right? There's no way I'm not going to cook. I may not even bother to even try to eat or get something to eat. Depression, loneliness, loss of a partner or family member, no transportation, no money, right? Those are all barriers to nutrition. And we know that the healthy foods cost more than the unhealthy foods,
Ugh.
right? You can go and get processed food all day long for pretty cheap, but you try to buy the healthy food and it's almost twice as much, right? So that's a huge barrier. Um, so, think about these, the patients that are 65 and older, and they're struggling with all of this. So, which factor promotes adequate nutritional intake in our older adults? So, remember your barriers. Okay. So, which of these promotes adequate nutritional intake?
Having a scheduled transportation.
I think it too.
All right. Yes, absolutely. So, scheduled transportation. Your friend is going to be there every morning, every Thursday morning at 9 a.m. to go to the grocery store, right? You have not only are you going to get your food, but what else do you have? You have interaction, you have socialization, right? That's two very important factors that we are going to see with this. All right. Oops. All right, fluid loss. So fluid regulation is one of our natural processes, right? Some types of fluid loss are abnormal and we need to monitor them. So what type of fluid loss are normal? What's normal fluid loss for us?
Urine.
Urine,
Respirations.
Sweat.
sweating, respirations, right? We lose a little bit in our stool as well, right? What are some abnormal fluid losses?
Vomiting.
Vomiting,
Would like skin secretions be one?
absolutely. Blood loss, absolutely.
Would mucus be considered
Coughing
one
up
or
the
no?
cold,
If we had excessive mucus, it could potentially. All right. So urination, defecation, perspiration, respiration. Those are your normal fluid losses. Vomiting, diaphoresis, or vomiting, diarrhea, diaphoresis, which is excessive perspiration, not just the normal perspiration because it's 90 degrees outside. Okay. Wound drainage, right? So any kind of wound drainage, skin lesions, gastric suctioning is another fluid loss. There's a variety of reasons why somebody would need to have gastric suctioning. Good job. Good job, guys. All right, foods for health, right? So let's see. Um, all right, so let's talk about labs. All right. So which conditions would the nurse assess with these tests? All right. So let's start with hemoglobin and hematocrit. If my hemoglobin and my hematocrit are low, what condition does that mean? What if I have
Be
low
anemic?
iron? I'm sorry?
Anemia? Like anemic?
Anemia. Absolutely. Very good. BUN and creatinine. What do these measure?
Kidney function.
Kidney function. Absolutely. Albumin is
Urine.
nope.
Sodium?
Why
Albumin.
did I say urine?
Is it
It's
sodium?
okay. I'm sorry.
No, that's not sodium, right?
Albumin. What is albumin?
The 3.5,
It begins with a P.
Protein.
Protein. Good job.
protein. Okay.
Albumin is our largest protein. Awesome. Calcium. We know calcium is needed for.
Bones.
Good
DEXA
job.
scans.
Okay. What about glucose?
Sugar.
Sugar. Okay. Good job. So those are some normal ranges, okay? But that was awesome. You guys did great. You guys are super smart. All right, so then we're gonna jump into safety. All right, so types and extents of safety problems. So unintentional injury deaths among older adults in 2022, 227,000, 227,039. The largest number of deaths in 2022 were from accidental falls, 44,630.
Damn.
Yeah, that's huge, right? The most common safety problems, falls, choking and poisoning, burns, automobile accidents, and extreme temperatures. Okay, so your hypo or hyperthermia. So falling once doubles a person's chances of falling again. Think about that. You fall once, that doubles your chance of falling again. So many independent older adults are reluctant to report a fall because of the implication that they are frail and dependent. Okay. So, in addition to causing bodily harm, falls have a psychological toll on older adults, causing them to lose confidence and decrease their mobility. If I fell once, maybe I shouldn't move around as much, right? Maybe I just need to be a little bit more sedentary so I don't fall again. Risk factors, internal risk factors, talked about sensory changes, right? And I can't see as well, I can't hear as well. That increases my risk of injury. The decreased sensitivity to smell and taste increases risk of accidental food or chemical poisoning. Cognitive changes reduce the ability to recognize and process information. Your urgency and urinary continence, right? We talked about this with drinking fluids, right? If I have a hard time going to the bathroom, right? Or if I don't, urgency. How many of my female students have been pregnant? A couple of you. All right. So when you got to go, right? Especially when you're pregnant, you got to go, right? Like you got to get there. All right. And so if they have, even a male, older male, if they've got to go, right? What does that mean? I'm going to hurry up. I'm going to move faster, right? That increases my risk for falls. Bare feet or inappropriate shoes. Bare feet, right? What am I going to step on? Uneven floor, trip over a carpet, inappropriate shoes too. Especially with our older adults, we want to care for those feet, right? So they should wear really nice supportive shoes. Your physiologic changes, talked about these, decreased mobility, decreased flexibility, decreased muscle strength, slower reaction times, gait changes, altered sense of balance, right? Those postural changes, that orthostatic hypotension, right? All of those can affect our safety, going up and down the stairs, and think about what are some of the things that people have in their houses. They have throw rugs and they have extension cords and they have furniture, right? All that could potentially be in the way and cause somebody to fall. Thank you. Impact of cognitive and sensory changes. So cognitive or perceptual problems increase the risk for self-neglect, non-adherence, illness, and injury. So what visual disorder do you see in this image?
The pitch is blurry, so I can't see it.
Exactly. So what would that indicate?
I'm losing my eyesight.
Vision problem.
Cataracts.
Cataracts?
Okay?
Okay.
Cataracts, right? So imagine this is what you see, right? What if this is what you see?
Scary.
So cataracts not only, it's cloudy areas, okay? And so, if you can't see, that it greatly increases your risk for accidents, injuries, medication errors, nutritional deficits, right? I can't see what I'm eating, where I'm going, what I'm doing, right? So lots of impact on, on your life as a result of cataracts. Hearing impairment. So can interfere with the perception of danger, communication, as well as teaching. So you're going to provide patient teaching, and they can't hear what you say. So a lot of people are just going to say, uh-huh, yes, yes, right? Um, so when we communicate with somebody that has hearing impairment, you want to use a lower tone of voice. You don't want to go really high pitch. You want to talk slow. Or not slow. You want to talk normal. You want to not over enunciate your words, okay? Because a lot of people that have hearing deficits can compensate by reading lips, right? So you don't want to exaggerate when you're talking. You don't want to chew gum. You don't want to smile. You just want to make sure that there's plenty of light on your face so they can see your mouth. If they're lucky and have hearing aids, okay, we need to make sure that they're being cared for. Anybody work in long-term care now? I know some of you went to
Yes,
long-term care, okay. How many hearing aids get misplaced in long-term care?
all the time.
All the time.
It's, I swear, hearing aids and dentures are, it's like a nurse's worst nightmare in long-term care, trying to keep track of everybody's hearing aids and everybody's dentures. Because like if they don't fit right, people like to take them out. They'll put them on their tray and then they end up in the kitchen or in the trash can. And the next thing
Mhm.
you know, you're digging through trash because dentures are expensive, hearing aids are expensive. Um, but you need to make sure that they are clean, that they're cared for, that the batteries are replaced as necessary, and that they are put in correctly. Um, the hearing aids, they do need to be updated every so often as well, especially if the hearing continues to decline. That's another big thing. I had this one gentleman, he was really far from the nurse's station, but I can tell you every time he put his hearing aids in, because I could hear them squealing. And I'm like, let's go turn your hearing aids down, sir. And yeah. So again, making sure at the end of the shift or the end of the night, you're taking them out. Taking them out. They're putting them in a carry or some sort of a case to keep them safe. I forget what the cases are, but they help to remove any
Sure.
moisture and things like that from the hearing aids to help keep them working appropriately.
Mm.
Other things that can lead to safety issues, decreased cardiac output, decreased oxygen supply can cause vertigo or syncope, which is your fainting. We also talked about with the neurologic system, we talked about how we can't compensate as well and they get that orthostatic hypotension, but also neurologic disorders like your Parkinson's disease or your stroke patients that can lead to weakness and alterations in their gait and balance that increased risk for falls, arthritis as well. Parkinson's patients scare me. I'm not gonna lie, they scare me. They have to do this rocking motion in order to get the momentum to start, like to propel themselves forward. And you're just waiting. You're just like standing there, you're waiting, please don't fall, please don't fall. But it's just because of the disease process, right? They have difficulty walking, and they shuffle when they walk. They don't pick their feet up when they walk. So if there's throw rugs, extension cords, things on the floor that they could potentially catch their feet on, that's going to increase their risk for falling. Medications. Can't say enough about medications. So any medication that alters sensation or perception, right, or slows their reaction time or causes orthostatic hypotension is potentially dangerous, right, for our older adults. All right, so the nurse is interviewing a family member of a hospitalized 90-year-old client to assess for common problems associated with an increased risk for falling. Which questions should the nurse ask? What are some things that we should ask? So what are we talking about? What's the topic here?
Common problems associated with risk of fall. All
Okay.
right, so if we talking to you put it up.
Yep, I put it up. So which questions are we going to ask?
When the last time the patient fell?
Yes.
if they're left alone, if they need to be in bed rest.
Okay. So we're going to ask if they've fallen. What else are we going to ask?
The pain pill.
The pain pill question.
Good job. Pain pill.
I thought you were asking our opinion. Sorry.
Oh, no, you're
and
fine.
Number 4.
Yep. Any problems with urination, right? I gotta go, right?
And
number
five.
5.
Yep.
Well,
Does your mom
not-
have any difficulty falling asleep? Absolutely. Great job. So, has your mom fallen in the past year? When was the last time your mother took a pain pill? Does your mother have any problems with urination? And does your mother have difficulty falling asleep? Good job. Other external risk factors, right? Your environmental hazards, fire hazards, home security, internet safety, vehicular accidents, thermal hazards. This is a huge one now. We know for our older adults. How many older adults are getting scammed through the internet, right? People calling and telling them they have to pay money.
Or they got relationships.
Yep. Yep. It's just, just like, the gift card scams, you still can't go buy over a certain amount of gift cards, right? Because of all the wonderful scams that are out there. Some of our fire safety precautions, most house fires are cooking related, right? So keeping baking soda on hand, making sure that we practice safety in the kitchen, making sure they have smoke detectors, right? Use caution with cigarettes or open flames. Make sure there's no open flames of any kind if there's oxygen in use. Check your extension cords for fraying or loose plugs. Report safety hazards. Call fire department if the landlord doesn't address fire hazards. Have an escape plan. And of course, we know we don't use elevators within, when there is a fire. And then I'm going to go to this last one. Drivers over 65 have the highest crash rate per mile driven. Okay, so I'm going to end there. What are some reasons, before I let you go, what are some reasons that are warning signs that a person should stop driving?
They're not
Poor
able to
vision.
behave.
They hit somebody.
They hit somebody, poor vision.
You
Reaction
lose
time.
control over the vehicle.
Losing control, reaction time.
By that picture we seen earlier, definitely cataracts.
Cataract. Yes. So, as you get older, okay, driving gets, I don't know, I get a little bit more nervous about people driving. And when I drive home from work, it's like driving a NASCAR race. It's people drive really fast down here.
Older
I'm
people are all
I'm
white
from New York.
knuckles.
Huh?
Older people are all white knuckles because when you see them holding the steering wheel, they're clenching for dear life.
Yep. And so that's a warning sign, right? Give it up. Give up driving, right? If they can't, if they're confusing the brake and the gas pedals, if they have
And
trouble
nerves
staying in their
bad.
lane. I'm sorry?
And their nerves real bad too.
Yep. What if they're, or even getting lost, right? That's another sign that they definitely need to quit driving. So you guys did awesome.